Okay, we'll go ahead and get started with module 4. This will be mood disorders. And just know that you can always go to the DSM-5 that is available under the course modules, the course module, course resources. So know that you do have access to that for any assignments or exams. Okay, so again, this will be module 4, mood disorders. All right, so when we talk about mood disorders, we're specifically talking about disorders in which there's gross deviations in mood. So this means that there's considered to be kind of a spectrum of what is considered to be normal mood, so to speak. There's kind of a baseline. And so these gross deviations can be either basically heightened or lower. So you have a spectrum, and you'll basically have moods that are too far one way or another way. Again, think of it as having poles basically. And so we'll talk about what happens on these two poles, for example, depression and mania. And they're composed of different types of mood episodes, these disorders. You might have periods of depressed mood, again, at one pole of the spectrum, or elevated mood. And this can last days or weeks. And these episodes are major depressive, manic, or hypomanic, and we'll cover all of those. So there's two different types of mood disorders. You have a unipolar mood disorder. This is when only one extreme of mood is experienced. There's only one gross deviation in one direction. And so with these disorders, you're only going to experience depression or mania. Again, uni means one. You're only going in one direction. And of course, depression is going to be much more common than mania by itself. We don't see that very often. But then you have your bipolar mood disorders. And again, you're looking at the two poles of deviations in mood. And so it's both of them. And these disorders have both depressed and elevated moods. And so you might have some depressive episodes, some manic or hypomanic episodes. So you're working on both ends of the pole. So again, let's start with major depressive disorder or depressive disorders. These are going to be your unipolar ones. And of course, we will talk about major depressive disorder. That's probably the most common one of the most common disorders people think about in general. We have persistent depressive disorder, premenstrual dysphoric disorder. That is commonly or historically thought of as PMS. It has now become an actual clinical disorder that can be diagnosed. And we have disruptive mood dysregulation disorder. Now, these all are characterized by a range of symptoms, but you only need a certain number of symptoms. So we'll go over all of the symptoms, and it's just important to know that, again, you might have enough symptoms to be diagnosed, but your symptoms might be different than somebody else's. So it's basically a mixing and matching game. And so not everybody that has one of these disorders is going to experience it in the same way. So for a major depressive episode, okay, so this is in regard to just an episode. We're going to apply this type of episode to both major depressive disorder and bipolar 1 disorder. Okay, so we're just talking about an episode. We're not talking about the full disorder yet, because we can apply this concept to two different disorders. So here's what you need to have present in order to have a major depressive episode. You're going to need 5 or more of the following symptoms. And these symptoms have to last most of the day, nearly all of the day, for at least 2 weeks. So for the majority of the time, for at least 2 weeks, you have to have at least 5 or more of the following symptoms. Okay, so depressed mood most of the day, nearly every day, as indicated by things like feeling sad, empty, hopeless, or observation made by others. Again, so maybe somebody else is saying that you seem extraordinarily down. And I know that the DSM doesn't delineate between these two, but if I were to define the difference basically between sadness and like being depressed, so to speak, or hopeless or empty. Sadness is a little bit different than depression. Sadness, there's still some aspect of hope. Okay. I mean, something bad happens to you, maybe, or you lose a job or you move away, something like that. You're probably going to feel sad, but there's a certain amount of hope. So you're in a tunnel and it's dark, but there's light at the end of the tunnel. And that's in comparison to depression. And the way that I would conceptualize depression is you're in that tunnel, but there's no light at the end of it. You can't see any light. So there isn't necessarily any light at the end of the tunnel. And that's why with depression, might get that emptiness and hopelessness because there truly isn't any light. And even if you logically know that there will be light if you just wait it out, when you're in that tunnel, that logic doesn't come through because in that moment, there is only darkness, and that's all that basically encompasses you. And so to get past that and logically realize, like, if I just wait it out, there will be light at the end of the tunnel if I keep going. That isn't always what happens when somebody is in the midst of a depressive episode. Even if they, quote unquote, should know that, they don't know that. Okay, I digress. Okay, with number two, they lose interest in or pleasure at all in activities that they once had interest in. So maybe they start to isolate more. Maybe they aren't going out with friends as much. Maybe they're not going out on walks or taking part in hobbies that they used to. And when we talk about like loss of like pleasure, I mean, you're talking about what's called anhedonia, and that'll come up throughout this course. Also, there may be significant weight loss or weight gain, so one way or the other, and it's about 5% of body weight in a month. That's what is usually considered significant. Also, insomnia or hypersomnia, either not sleeping at all or sleeping all the time. Again, it could go either way when it comes to a depressive episode. Also, let's see here, fatigue or loss of energy nearly every day. So you can't get up, can't get going. That is another symptom. Feelings of worthlessness or excessive or inappropriate guilt. And they can be delusional. And we say delusional, they're not real, but the individual that's feeling them believes that they are real. And they feel this way nearly every day. And it's not just like guilt about being sick, it's guilt about possibly even existing or being a burden to other people or not being worth anything on this planet. It's excessive worthlessness and guilt. Let's see here. Yes, a reduced ability to think or concentrate, not being able to make decisions. Again, nearly every day. Of course, there's times when we have make a hard time concentrating or making decisions, but this is every day most of the time. Also, let's see here, psychomotor agitation. And what this is that basically they have a hard time sitting. They have a hard time sitting. They have a hard time just kind of not being jittery, anxious, restless, or psychomotor retardation. And so with that one, they're having a hard time getting up and going. Everything is slowed down. Their thoughts, their movements, everything is slowed down. So again, it could be one way or the other. And then finally, and I think I might have missed this on here. There's one on here that I don't, oh, sorry, I'll bump back up. The DSM is a little different here. So, you probably noticed by now that I went right past suicidal thoughts. Yeah, recurrent thoughts about of death and just not fear of dying. That's very common. Not just fear of dying. Potentially just suicidality, thinking about death or dying, suicidal ideation. Okay, so thinking about dying without having a specific plan, or the next step would be thinking about dying with a specific plan. That's usually where uh, the threshold is, and that's where it gets, it's obviously all extraordinarily concerning, but very concerning once there's a plan in place. There's possible intent there, a plan to get materials. They've thought this out. That's where you're looking at extraordinarily concerning. Or okay, so you have suicidal ideation with a plan, then you might have an attempt. um, and so that would also be included. And then also, even with suicidal thoughts, it can also include if they've attempted before. And so this is a big reason why this is an extraordinarily life-threatening, uh, why depression is so life-threatening in and of itself. Okay, so with that being said, um, along with, I'm so sorry, along with this, the symptoms have to be clinically distressing, dysfunctional, and deviant in nature. It's outside of the norm. It's absolutely outside of the norm to, be planning how one is going to kill themselves, or feeling worthless all of the time, and not being able to sit down, or eating too much, eating too little. That is outside of the norm. When it comes to dysfunction, yes, if somebody's experiencing these things, they might have a hard time getting out of bed. Again, they might be isolating themselves. They may not be going to work. They feel guilty about everything. That is dysfunctional in nature. And then, of course, we have distress. Again, feelings of worthlessness, the suicidal thoughts. All of that is distressing to the individual. The hopelessness, the emptiness, that is distress. And again, you also have to make sure that this is not part of or attributable to any sort of physiological effects of like taking a substance of some sort or any other medical condition. If this is all in place, you would have the criteria to diagnose somebody with a major depressive episode. Okay. And usually a single episode is highly unusual. And part of that is because usually if somebody just goes through one single episode and never has another episode again, they probably don't show up for treatment or help. They experienced it once and then everything went back to normal and things were okay. We do obviously see recurrent episodes more commonly because these are the individuals who come in and get treatment and get help. And these are the individuals that are probably going to be diagnosed with a disorder. And so we do see those recurrent episodes more commonly because these are the individuals that come in for help, whether it's after one episode or whether it's after 100 episodes that they've had. Yes, in 2020, an estimated 14.8 million US adults 18 or older had at least one major depressive episode, which is pretty excessive, with severe impairment in the past year. This represents about 6% of all US adults. So about 1 out of every 20 people 18 and older are going to have a major depressive episode in the next year. Also in 2020, and it will be also very interesting to see what these numbers look like once we have all of the numbers from COVID. Because we do know that that caused significant psychological distress for literally societies internationally. And so once we have those numbers, I would not, it might be easy to say that these numbers probably jumped. But nonetheless, in 2020, an estimated almost 3 million adolescents between 12 and 17 had at least one major depressive episode. And again, so this is going to represent about 12% of the US population between 12 and 17. So it's, instead of adults, which are 1 out of 20, this is 1 out of 10 kids, more than 1 out of 10 kids. And this is a very sensitive point in time, obviously, for adolescents, and they're going through immense amount of changes in their life personally. And so this is a time of great change in and of itself. And to add these depressive episodes is that much more concerning, so to speak. Okay, there's a couple other things. Okay, figure below shows the past year prevalence of major depressive episodes among US adults, again, 18 or older. These numbers are a little bit different, but still about 1 or 2, 1 out of 20, 1 out of 10, somewhere in between that. Prevalence of major depressive episode higher among adult females, 1 out of 10, males about 1 out of 20. It was highest among individuals aged 18 to 25. That's about 17%. So now we're heading more towards 1 out of 5 individuals between 18 to 25. Again, there's a lot of life changes happening. Additionally, this is commonly where we see major depression, major depressive disorder rear its ugly head, and people start having symptoms, whether for genetic or environmental reasons. And the prevalence of a major depressive episode was highest among those who are more than one race. And that's about 15.9%. So again, almost 1 out of 5. And that's not surprising by any means, as the stigma, prejudice, discrimination toward those individuals is much higher than others. So, and you can see that data down here. Again, much higher individuals 18 to 25, 2 or more races. Also, the past year prevalence of major depressive episodes among adolescents, again, about 4.1 million adolescents, about 17%. The prevalence of major depressive episodes was highest among adolescent females, 1 out of 4. Incredibly high rates. 1 out of 4 adolescent females are going to experience a major depressive episode, compared to males, which is about 1 out of 10. Still concerning. But the prevalence of major depressive episodes was highest among adolescents, reporting, again, 2 or more races, 1 out of 3. 1 out of 3 kids that report being multiracial are experiencing these depressive episodes. Okay, so now we get into major depressive disorder. So now we have a major depressive episode. Okay, and so literally what we do with a major depressive disorder is you have to have symptoms lasting 2 weeks or more, which again, you're going to have, and 1 or more major depressive episodes separated by periods of remission. So what that means is that, yes, somebody is having a major depressive episode for at least 2 weeks in time. And then there's a gap in that maybe they come back up to baseline a little bit. They come back up to baseline a little bit, maybe for a couple days, maybe for a couple weeks, months, and then they drop back down into that depression. That's important, is there's gaps between these depressive episodes. That's going to be required in order to have that major depressive disorder diagnosis. So again, symptoms 2 weeks, and 1 or more depressive episodes, again, separated by periods of time. And we just went over all of the criteria that constitutes a major depressive episode. And so that is the first part right here. Let me see here. Yes, you only need 1 depressive episode for a doctor to diagnose. But then additionally, they have to make an impact on functioning, like we talked about, social work, their work, personal life. And it can't be related to any other medical condition, substance abuse. And also there can never have been a manic or hypomanic episode. So that means, okay, so literally no mania, no hypomania. That will make sense once we get to bipolar disorder. Because if those have ever been present, it's not major depressive disorder. You're looking at a bipolar disorder. And you have to make sure that you would have to do a differential diagnosis and make sure there aren't any other potential diagnoses like schizophrenia or other psychotic related disorders as well. And that is how you would get to a major depressive disorder diagnosis. So we don't really know exactly what causes major depressive disorder. A lot of people, not a lot of people, I mean, it can commonly be thought that like, oh, it's genetic in nature, or oh, there's just things somebody went through in their life that caused this, but it's really much more complex than this, or it's a lack of serotonin in the brain. That's just not the case for most people. It might, those things are might be the only cases, the only influences for some people, but for most people, it's so incredibly complex to the extent we really don't know. But it's a complex interaction between genetic and environmental factors, and there's a lot of different brain regions affected that result in a multitude of combinations of symptoms. So again, not everybody's depression is going to look similar. People might expect like certain stereotypical symptoms to be present, but that's just not the case. Okay, and before I go too far, I did want to Give a few numbers here. I usually do this with like suicidal thoughts or behavior. In regard to how major depressive disorder influences those suicide rates. Let's see here. Individuals with major depressive disorder have about a 17 times increased risk for suicide over the general population rate. So just to put that in there. Let's see here. So some of the symptoms related to major depressive disorder that enhance this, like the anhedonia, not being able to feel pleasure, interest in things you once did, being single, living alone, social disconnectedness, early life adversity, and the available of lethal methods like a firearm as well. Women do attempt suicide more often than men, but men are more likely to complete suicide. There's a variety of possible factors for this. One of them may be that women attempt suicide using potentially less lethal means like pills, whereas men may be more prone to use more lethal means like firearms. But again, those are just those are theories. So let's get back on track here in regard to treatment of major depressive disorder. Major depressive disorder is commonly treated with psychotropic medications. And this is backwards, so just bear with me. So we have examples of SSRIs over here, and then our SSRIs are in the purple, whereas your SNRIs are over here, and they're in the blue. I do apologize for that. So we have examples of SSRIs. This is going to be your selective serotonin reuptake inhibitors. And if you remember from intro, we talked about what happens when somebody takes an SSRI. SSRIs are based on the theory that depression results from a lack of serotonin activity in the brain. And so when somebody takes an SSRI, that makes serotonin that much more available in the brain. And what happens is that within the synapse, serotonin is going to be released. And the effect of the SSRI results in that reuptake process not happening, thus increasing the availability of the serotonin in the synapse to basically be received by the attaching neuron and increasing the activity of serotonin in the brain. So again, that was the initial theory with depression, is that there's a serotonin issue. But as we get going here, you're going to see that very few people find relief with SSRIs, possibly indicating that it's not necessarily a serotonin deficiency that's causing depression. Nonetheless, some examples of SSRIs. Again, we're inhibiting the reuptake of serotonin. We have like Celexa, Cipramil, Cipralex, Lexapro, Luvox, Paxil, and Prozac. Some of those are going to be fairly familiar. Zoloft is in there as well. I don't know why I don't have it there. Then we have what are called SNRIs. So we kind of started to figure out that serotonin isn't the only neurotransmitter involved in depression. And we still don't know all of them, but we started to realize like, hey, this isn't working for everybody. So maybe it's something else. And so as a result of that, we developed SNRIs, and SNRIs are selective norepinephrine reuptake inhibitors. So instead of just blocking the reuptake of serotonin in the brain, it also blocks the reuptake of norepinephrine, which is also now thought to be a factor in depression. And this can be related to, we talked about like the fatigue or the psychomotor retardation, just the slowness, everything is slowed down, sleeping too much. That could be the result of a lack of norepinephrine, which again is a excitatory neurotransmitter in the brain. And so the SNRI works with both of those neurotransmitters. Let's see here. So your SNRIs, you are looking at medications like Effexor, Cymbalta, Pristiq, and Fitzema. So those are just a couple of examples, but again, you have your SSRIs that just work on serotonin and your SNRIs that work on the serotonin and norepinephrine. So they're working on two different neurotransmitters. Now, when it comes to antidepressants, and we're talking about SSRIs and SNRIs, they're going to be effective in basically half to 2/3 of people. That leaves a lot of people out there. And some estimates indicate that's actually a high estimate. Yes, they do increase serotonin in the brain. The SSRIs and SNRIs, they do take several weeks to gain full efficacy. So when somebody's put on one of these antidepressants, they're usually told that, it could be, 4 to 6 weeks before you actually feel some relief. But here's the thing is that we do know that these antidepressants actually increase serotonin very quickly in the brain. That activity happens pretty quickly. So what that indicates is that it's probably something else that is going to be causing the depression, because why, if that serotonin activity is increased in the brain, why are people not experiencing relief from depression right away if it's truly related to serotonin? And again, that's the question here. Why is that happening? So it's not an absolute truth that a lack of serotonin in the brain causes depression. If it was, then somebody would be feeling relief from depression very quickly. It wouldn't take 4 to 6 weeks to gain full efficacy, but it does. And here's another thing, in that some people, again, somebody might be put on an antidepressant and it doesn't work well. Then they try another one and another one. And there could be a multitude of antidepressants that somebody goes through before one may work. But just as a note to everybody out there, if you do, or somebody you love tries 2 to 3 antidepressants and they don't work, you should be labeled as treatment resistant. Once you are labeled as treatment resistant, this opens up the doors to a vast array of newer treatments that can include everything from ECT all the way to ketamine treatment or therapy. So just know that 2 to 3 antidepressants, if they don't work, there might be one down the road that does, but you can be labeled as treatment resistant at that time. Okay, so again, when it comes to antidepressants, again, what should happen if it is only serotonin involved in depression, what should happen is the depression should lessen immediately. There should be relief from the depression. But again, we know that's not what happens. And it takes about 4 to 6 weeks for somebody to feel a little bit better if the antidepressant does work. And so what we're kind of seeing is that there's actually, with these antidepressants, actually neural rewiring that might be happening. Ketamine also does this, but at a much faster rate. And so it's not necessarily the result of depression, isn't necessarily the result of these neurotransmitters, but it has to do with wiring in the brain. And so that research is showing that neural rewiring, so neuroplasticity, so that means that there's new connections being made between neurons. It's occurring over these weeks that might be impacting the levels of depression and not the activity of serotonin. And so when we talked about brain-derived neurotropic factor genes, these are growth factors that are going to play an important role in the development and research indicates antidepressants impact this growth factor. So what this indicates is that studies have shown that when this gene is altered, antidepressants has zero effect. But what we see is that when researchers change one amino acid in this gene and thus lowering the activity of this BDNF, there is less responsiveness to antidepressants. So in the case of antidepressants, we see that BDNF, again, that neurotropic factor that we're just talking about, is involved in activity in the hippocampus, which we've talked about in regard to learning and memory. All right, so just to hold up right there, remember the BDNF. Genes are in every cell in the body. And again, when they're expressed, they can be made into proteins that have specific functions in neurons and impact how a neuron functions. So it might be the difference between whether a neuron is a sensory neuron or a motor neuron. Again, that's based on genes. And neurons communicate with each other in the synapse through neurotransmitters, which we've talked about. And when these neurotransmitters are released, some has fast effects, so like glutamate, GABA, whereas others are a bit slower. Serotonin is going to be slower having an effect. Okay, so we need to bring ketamine in to the discussion here. Okay, good. So ketamine is a dissociative anesthetic. It's used medically for the induction and maintenance of anesthesia, and it's used as a recreational drug. And when it's used in very high doses, it is anesthetic. And you'll find ketamine in like veterinary offices, people who use, and that's where the anesthetic comes into play. Moderate human doses, this is going to result in dissociation. So it is considered to be like a depressant and a hallucinogen, but at low doses, it is an antidepressant. And this is where ketamine therapy does come into play, because we do know that ketamine is very fast acting. So if you give somebody with depression ketamine, it can provide an antidepressant effect within 30 minutes to 2 hours. And that's in direct comparison to your antidepressants. Antidepressants will probably not gain full efficacy until 4 to 6 weeks, whereas ketamine, we're talking within minutes to hours. And this effect can last from days to weeks, but you can't necessarily just take ketamine. There has to be a certain amount of therapy, talk therapy, that goes along with it in order to make those long-term effects. So we just talked about glutamate. Glutamate's going to be one of those neurotransmitters that works very quickly in comparison to serotonin, which is very slow acting. So when we talk about glutamate here, ketamine does focus on glutamate. And specifically, it blocks what's known as the NMDA receptor that glutamate binds to. And you can see that right here. So these boxes blocking that glutamate. So when this is blocked, it prevents calcium from entering the receptors, which is crucial for the antidepressant effect. And what happens is it causes a downstream. So it's like a chain reaction causing, and you don't need to know this, but just to throw this in there, the EEF2K kinase upregulating protein synthesis, increasing the protein at the synapse right here. And one of these proteins is BDNF, that neurotropic growth factor we were just talking about. And what this does is it activates the process to produce a unique form of plasticity, specifically in the hippocampus. So that's where we're getting here, is that this ketamine works on the glutamate. And when that is blocked, what we're seeing again is this downstream protein synthesis resulting in BDNF, activating neuroplasticity in the hippocampus. That is actually going to spread throughout the brain. That's what you really need to know. And so when we look at the hippocampus after somebody uses ketamine, the neuroplasticity happens quickly again. So there are connections that are being made in the hippocampus as a result of the ketamine. But what happens is that as that time goes on, and about a week later, the neuroplasticity isn't happening anymore. But this is why like therapy is important with ketamine therapy, because you need to be able to be learning new techniques, new coping skills, new ways of looking at yourself if you are depressed. Because what's happening is in the hippocampus, these connections are being made, and so it's enhancing learning. It's enhancing memory. And so hopefully you're doing that additional therapy, which is going to just be that much stronger. But I digress. We have discovered that this neuroplasty, it transfers information to the prefrontal cortex. So what's happening here over a week's time is that neuroplasticity was initially in the hippocampus, again, kind of in the center of the brain, and then it works out to the prefrontal cortex, which is right at your forehead. And it moves out so the behavioral effects can last longer than several weeks, even though the action of neuroplasticity has ended in the hippocampus. So what's happening is what is learned in the hippocampus is moving out to the prefrontal cortex to basically be saved and enhance these executive functioning things. And over time, the drug has a cumulative effect. And so again, as the individual continues with this ketamine therapy, again, it's just like you're learning more and more and more, and more connections are made, especially if you're like in therapy, enhancing the effect of that therapy and these new connections. And again, that information is going to be sent to the prefrontal cortex. And again, there is a downstream pathway causing long-term effects that's initiated by that initial neuroplasticity. And again, over time, additional doses of ketamine are going to result in increased neuroplasticity in the hippocampus. So again, these connections just keep being made. And the message is then stronger and better to the cortex and other regions of the brain, resulting in longer antidepressant effects. Again, so what's happening, it's like these new connections that are being made with additional ketamine therapy are just made stronger and stronger and stronger and stronger, which means that they're going to be more powerful, enhancing that antidepressant effect. So that is why ketamine is such a powerful potential antidepressant. And that glutamate, the activity of glutamate is very quick acting. Again, in comparison to serotonin, it's just very, very slow. And that might indicate why SSRIs are not as effective as, say, ketamine therapy. Because ketamine has been found to be effective in about 60% of treatment-resistant patients. So again, we're looking at about half of people are resistant to antidepressants in the first place. 60% of those that are treatment resistant to those, ketamine works. So when nothing else has worked, 6% of those people find that ketamine does work, which is extremely significant. And when it comes to the administration of ketamine, you do have to be given it regularly because the effects aren't going to last forever. And IV administration is primarily being used, but you do have to go to a clinic for that. And if you're out in the middle of nowhere, like most of us are who are probably listening to this, that might be very difficult. You might have to go Lincoln, Omaha, Denver for this treatment, but Johnson & Johnson now has a nasal administration of ketamine, which is going to allow for more access to individuals that do not have transportation or are in proximity to a ketamine clinic. So this is also indicating that ketamine is extremely effective. We don't know exactly what neural circuitry is causing depression. Okay, we just don't. But we do have an idea that it is neural circuitry. It's not just specific neurotransmitters here and there that just aren't doing what they need to. But theoretically is most likely a wide variety of circuits because when it comes to depression, as we talked about, the symptoms are so far reaching and like different, and there's just a multitude of them, and nobody's depression is the same as somebody else's. So it's so complex. It's so complex that we really don't know a lot. We commonly assume like medications are fixing issues related to depression. But again, research shows we're not fixing the problem, but with ketamine or even with some antidepressants, we're inducing new forms of neuroplasticity that masks symptoms to make us feel better. So there is no fixing. The best that we can hope for is, like we talked about with ketamine, that this neuroplasticity is enhanced, potentially alleviating some of the symptoms of depression. That's where we're at with ketamine and depression right now. Okay, let's go through just a couple of other unipolar disorders. Then I'll take a break and I'll come back with another video. So hopefully we can break this up into two. But with persistent depressive disorder, this is a milder depressed mood. But here's the difference. Whereas with major depressive disorder, we were looking at the symptoms for most of the day, every day for 2 weeks. Here, we're looking at the symptoms most of the day for 2 years. So it's a lower level depression, but it's every day for at least 2 years with no remission. That's what's going to make persistent depressive disorder different from major depressive disorder. It's milder and lasts most of the day for 2 years. And to get a diagnosis, you have to have at least 2 of the major depressive episode criteria. So that could include like poor appetite, overeating, insomnia, hypersomnia, low energy or fatigue, low self-esteem, poor concentration, feelings of hopelessness. So you need at least 2 of those. And during the 2-year period, you've never been without the symptoms in criteria A, again, depressed mood most of the day, or B, for more than 2 months at a time. That's the poor appetite, insomnia, low energy, low self-esteem. So yeah, you have to experience at least 2 years of these symptoms most of the day on more than half of the days. Again, you no more than 2 months without symptoms. So you cannot have long periods of remission. And there might be periods of more severe major depressive symptoms, but not long enough or intense enough to get a diagnosis of major depressive disorder. So there might be like 5 days where somebody is majorly depressed, but it doesn't reach that threshold of 2 weeks. Also, just to throw in here, again, has to be for at least 2 years. There's never been a manic or hypomanic episode. There's a differential diagnosis. There's no substances involved, and there is significant distress, dysfunction, and again, deviance outside the norm of what we would expect somebody to feel like. Okay, let's see here. And these are the courses of depressive disorders. So this is A is going to be major depressive disorder. And these are going to be two, again, we talked about remission. So this is one major depressive episode, remission, another major depressive episode. Panel B, this is persistent. Again, it's not as severe as A, but there's no remission, as we just saw here. There's no remission. It's milder, but there's no gap. Let's see if there's any others on here. Chronic major depression. D is chronic major depression. So basically an episode that doesn't really have any remission. Let's see, major depression and partial remission. So again, you have the major depression episode. You're going into about half remission here, not full remission. And same thing down here. So the biggest one is like looking the difference between A and B. Again, deeper depression with a remission, milder depression, no remission. Okay, then we have premenstrual dysphoric disorder, again, used to be known as PMS. Significant depressive symptoms occurring prior to menses during most cycles, leading to distress and impairment. Okay, and you have one or more of, oh shoot, this is a little bit different on here. So according to the DSM-5 TR, this is going to be a little different than what you're seeing on the screen. You have one or more of the following symptoms that must be present. Marked affective liability, so like mood swings, somebody suddenly tearful, increased sensitivity to rejection. That would be the first one here. Irritability or anger, or increased interpersonal conflicts. Depressed mood, hopelessness, or self-deprecating thoughts. I'm just not good enough. I suck at everything. See, these aren't quite right. And then anxiety, tension, or like feeling keyed up or on edge. So you need one of those. And this will be in your DSM-5. I apologize for whatever's happening on the screen. Then in the next category, you have to have one or more of the following symptoms. And you have to end up with a total of 5 when you combine A and B. So overall, you have to have at least 5. That part is correct. But you have to have like decreased interest in usual activities. So you aren't interested in going to work, being with friends, doing hobbies, having a hard time concentrating. You're easily fatigued, change in appetite, overeating, having specific food cravings, you sleep too much or too little, a sense of being overwhelmed or out of control, and then breast tenderness, joint or muscle pain, bloating, weight gain. And so again, you're going to need about, these are pretty close, about 5. You're going to need at least 5 of these in general, though they're missing a couple here. And again, these symptoms have to be present in the final week before menstruation starts. And then within a few days after menstruation starts, they start to improve. So it gets better. And then they become minimal or absent in the weeks post-menses until the cycle restarts again. And again, these symptoms have to be getting in the way of life. They have to be distressing. They are outside what is quote unquote normal, and they are getting in the way of one's life. Let me see here. And so the 12-month the 12-month prevalence of this disorder, it's right around 5.8%. So about 1 out of 20 women, biological females, are going to experience this over a 1-year period of time. Let's see here. So, but then there's another estimate of this disorder in the United States. It's right around 1.3%. So, and the prevalence of this in adolescent girls may actually be higher than in adult women as well. So I guess that's a pretty big gap between somewhere between 1 and 5% of women do deal with this disorder. So that's premenstrual dysphoric disorder. And that is going to conclude the unipolar mood disorders. And so as a result of that, I'm going to stop the recording and then I will come back with the bipolar section of mood disorders. So I will see you soon.